Okay. Hello, everybody. My name is Sunshine. I'm one of the pharmacists here, and I get to join you all to discuss vasoactive medications today. We're really excited to see so many of you. All right, so there is a lot of material as you look through this PowerPoint slide. You'll see there are a lot of slides. We're going to fly through some of them, but I just wanted you to be able to have the material readily accessible for when you want to review it. Next. Thank you. It's okay.
I'm not sure which.
All right, so the first slide, this just reviews some of the pretty typical definitions that we'll refer to several times within this conversation. Titration, I'm assuming you guys are all pretty familiar with that phrase, but it involves increasing or decreasing the rate of a medication in order to reach the therapeutic goal that you're looking for that patient. So that could be for heart rate, for blood pressure, for pain control. We do titrations for a lot of different things. Then there's vasopressors, which cause vasoconstriction and increase your blood pressure. Inotropes, which affect the strength of heart muscle contraction, and there are negative and positive inotropes, which we'll talk about in a second. Catecholamines, which cause the sympathomimetic action, which how many of you guys know what that is?
The pathomimetic?
Yeah.
It behaves like a sympathetic
Nervous system, which causes fight or flight. Thank you. All right, and then adrenergic, which is just secreting substances like epinephrine or norepinephrine, anything similar to that. So what are vasoactive medications? They're any medications or substances that are already inside the body that would increase or decrease your blood pressure or heart rate, and they act on the blood vessels, so that's the vascular activity. They fall pretty typically within three main categories. So there's vasopressors, inotropes, and some medications will fall into both of those. Inodilators, which there's one medication that we'll refer to that falls into that category. And then they have a miscellaneous category for the medications that don't exactly fit neatly into any of these. So for vasopressors, these are drugs that cause the arterial vasoconstriction, and by doing so, they increase your blood pressure. So a lot of the times in ICU, I'd say at least half of the time, we end up with patients who are on one vasopressor or another. Four of the main vasopressors are also inotropes. So that would be norepinephrine, epinephrine, dopamine, and dobutamine. And then phenylephrine and vasopressin are just vasopressors and do not have the same inotropic action. All right, then for inotropes, we have negative or positive. So the negative inotropes cause a decrease in the cardiac workload, and by doing that, they end up decreasing your blood pressure. So you would think of beta blockers, calcium channel blockers like diltiazem and verapamil. The positive inotropes end up increasing your cardiac workload and increase your blood pressure. So that would be the vasopressors that we just referred to earlier, like dopamine, dobutamine, epinephrine, and norepi. So when would vasopressors be indicated? A lot of literature has some slight variations within when exactly you would initiate a vasopressor. So some say if systolic drops greater than 30 millimeters of mercury from that patient's baseline. Others say if the mean arterial pressure is less than 65. Some say if it's less than 60, but you want to keep that general ballpark. And then if the patient meets either of those two criteria, and they result in end organ dysfunction that could result in hyperperfusion, then you would want to initiate a vasopressor. This can be in situations such as hypertensive crisis, flash pulmonary edema, sepsis, shock, some patients with AFib, not all, SVTs, heart failure, and any of the patients who are hemodynamically unstable. So the first thing you have to do before initiating a vasopressor, does anybody have any guesses?
increase the volume.
Thank you. All right, so you first have to correct the hypovolemia. Now, most of our septic shock patients will typically require about 2 liters of fluid to be infused before any of the vasopressors can really become effective. So if the patient has low volume, any vasopressor that you give will either be minimally effective or just not effective at all. So it's very important whenever possible to be able to correct the volume first. There are, however, instances when you need to withhold the fluids. So that would be patients with CHF and those with significant pulmonary edema. A lot of the times it'll still fall to the physician to decide if the patient has that condition, whether or not you still need to proceed and give some fluids to provide additional balance in order for the vasopressors to be able to be effective. Now, when administering vasopressors, it's preferred for all of them to administer via central line, and that is because it causes severe tissue injury if they were to infiltrate. So normal infiltration, it can cause a little bit of irritation. You can apply cold or warm compresses and it'll calm down pretty quickly. For patients who would receive a vasopressor that infiltrates, it's going to be considered extravasation because they are vesicants. So there is one antidote for extravasation of Levophed, and it's only indicated for Levophed, but it is used off-label for every single one of our vasopressors. And at some point down the line, they do imagine it will become a labeled indication for the others, but so far it only has a label for Norepi. The other thing that is required is clear titration and hold parameters, which you'll notice if you look through EPIC orders that you receive, they all are very detailed in terms of you need to have exactly what systolic blood pressure you're looking for or stopping and titrating for. What heart rate, what oxygen saturation, any of these things needs to be spelled out very clearly before the patient is able to be initiated on that vasopressor. And part of a pharmacist's job is checking to make sure all of those parameters are clear and easy for you guys to be able to follow. And if a patient has more than one vasopressor on board, you need to make sure, again, that it's very clear what instructions that you guys need to follow in terms of when you would titrate one drip versus the other, or both. All right, so working our way through the vasopressors, we're going to fly through some of this material, but I just want you to be able to know where you can find it. So, Levophed, it's a potent alpha and beta agonist, causes vasoconstriction, which thus increases your blood pressure, has a very immediate onset and a short half-life, which part of that plays into why you would not want to stop the medication abruptly, because it will very immediately wear off out of their system. So you'll notice that as a theme throughout most of these medications. If they have a really immediate onset and a very, very minimal half-life, then you wouldn't want to stop those medications too quickly. All right, so when would you use it? Goes based on what its action is, right? So for severe hypotension, shock, bradycardia, and Norepi is considered the drug of choice for septic shock, so that's important to remember. In terms of preparation, this is just available for you if you need it, but you typically won't have to prepare the medications here since we make them for you. You will want to look at it and make sure that the concentration is okay, and I have some of the medications that we'll pass around so you guys can look and see what they look like, so when you see it in a practice setting, it's more familiar for you. It has decent stability at room temperature. It is stable for 24 hours, but it needs to be light protected. So if it is without that light protection for an extended period of time, we have to make a new drip for that patient. In terms of starting infusion rates, the standard starting rate is 2 mics per minute. They can start at lower than that. That's just the typical starting rate. You would want to titrate upward every 20 minutes until the blood pressure is normalized. And typically you would shoot for a goal of mean arterial pressure greater than 65 or systolic greater than 60. But again, the providers can fine tune that, so you just want to reference back exactly what parameters that physician has ordered for your patient. It is also very important that the patient is on continuous telemonitoring, and when you are doing the titrations that you're monitoring vitals every 5 minutes.
So should that be a systolic pressure greater than 90?
No, so you would think so. But the clinical guidelines for Norepi does say that you just need to make sure that it stays above 60. So, yeah,
Wow.
yeah. But, yes, math is greater than
Do you
65.
ever have a
Yes.
map of 65 with a systolic of 60?
You shouldn't, no.
It says or.
I'm like, no, in practice you shouldn't. That's just the clinical package insert information.
Oh, okay.
All right. In terms of precautions, a lot of these things, again, fall back into what action does the medication cause and what would be the adverse effects for that. So it can cause arrhythmias. It causes an increase in cardiac oxygen need. You need to make sure to not use it with MAOIs or have at least a break in between, as they can cause some pretty serious interactions with them. They recommend not using with hypovolemia, but as long as you can correct the patient's volume first, then it's considered relatively safe. The extravasation antidote is phentolamine, which we carry here. Our standard here is to always use 5 milligrams rather than the listed dosing is 5 to 10. But we typically would do a 5 milligram dose that comes out as 10 mLs, and you would end up injecting 2 mLs in 5 different increments surrounding that area that was infiltrated. And again, it's only labeled for norepi extravasation, but they do use it for the other ones if needed. In terms of dose adjustments, you would want to dose adjust for geriatric patients and start at the lower end. They will respond a lot quicker to the medication, and you'll a lot of the times want to have a longer titration window in between. So rather than titrating every 20 minutes, you might want to wait every 30 minutes for someone who's elderly, just because they'll need a longer period of time rather than making quick adjustments on them. The other thing is for obese patients, they've found that they don't typically need to have the same weight-based dosing. So they give a recommended 3 mics per minute and then titrating up at 3 mics per minute rather than calculating out the dose per kilogram. And that's for anyone with a BMI greater than 30. All right, so moving on to the next one is epinephrine. It's also a vasopressor just like norepi. It stimulates the sympathetic nervous system and causes coronary perfusion. So indications: profound refractory hypotension, VFib, VTAC, pulseless electrical activity, asystole, and it is the drug of choice for cardiac arrest. In terms of preparation, again, we'll make them for you. But it has a short stability at room temp, so it needs to be started pretty quickly. It doesn't mean that that 4 hours is how long it's stable once it's already infusing. It just has to be started within that 4-hour time period. In terms of starting the infusion, you would typically start within the 1 to 4 microgram per minute range, and then you would end up titrating upward every 20 minutes. So it's the same time window as you would for Levophed. The usual dosing that you end up with is 2 to 10 mics per minute. If you end up having to go above 10, then you would want to consider a different agent, because they say that the higher doses for epinephrine is not associated with increased effect. So you'd want to keep that in mind. Again, you need continuous cardiac monitoring, but that's a theme throughout all of these. Like Levophed, it has immediate onset. And again, the half-life is 1 to 2 minutes. You want to make sure not to administer with alkaline solutions, which, can anybody think of any alkaline solutions off the top of their head? Ampicillin as well. Fosphenytoin, so if you have a seizure patient, you want to make sure that if they're on that medication that they're being administered via 2 different lines. Bactrim is also an alkaline solution. In terms of precautions and side effects, again, the higher doses are associated with greater side effects for epinephrine, so that's why they don't recommend increasing above the 10 mics per minute. If you can avoid it, do. It does cause hyperglycemia in a significant number of patients, so if you have a diabetic patient, you'll want to make sure that you're routinely checking their glucose. Even if someone doesn't have diabetes history, you'll want to be doing routine glucose checks on them as well, but diabetic patients might need a higher insulin coverage while they're on the epinephrine drip. It can also cause decreased urine output as well as metabolic acidosis. So you don't want to administer with sodium bicarbonate. For dopamine, it's our next one up. It is an adrenergic agonist. It is a catecholamine. It is a precursor to Levophed, and it is a positive inotrope and a vasoconstrictor. It does a lot of things, but the most important thing to know about dopamine is that it has dose-dependent effects. So depending on whether you start low or in the middle or at high, you'll have a different action of the drug, and it's almost as though you've completely switched medications. So for indications, because it can act in so many different ways, it has several indications that it's used for. It can be used for central hypotension, heart failure, decreased renal and mesenteric perfusion, and that's only when there is not concurrent hypovolemia. So again, always correct the low volume first. And in order to have that action against the renal arteries, you need to be using the lowest dose possible. So on one of the future slides, I lay out exactly what dosing parameters you'd want to use. The other thing to know is that dopamine is used as your drug of choice if you don't know the cause of shock. So in terms of preparation, a lot of the times we have premixes, which I'll pass one around shortly. You start typically at 5 mics per kg per minute, and then you end up staying within a dosing range of 2 to 20. The onset of action is a little bit longer, so it's not a rapid or immediate onset like Levophed or epinephrine. It takes about 5 minutes. The half-life is 2 minutes. Monitoring is pretty similar, except you also want to be monitoring the urine output. In terms of dose dependency, like I had just mentioned, the 1 to 2 mics per kg per minute is going to be where you act at the renal level, and it causes selective vasodilation there. At 5 to 10, or what they consider the moderate dosing range, it ends up stimulating the beta adrenergic receptors, and this increases the cardiac output and can cause various effects on your heart rate. So it's not very predictable in that middle ground. And then when you increase above 10 mics per kg per minute, it ends up acting at the alpha receptors. So this causes vasoconstriction. It is weaker than the Levophed that comes after. The other thing is that if you increase above 20, a lot of the times you'll want to end up discontinuing the medication or switching to something else, or adding Levophed on board. In terms of adverse effects, vasoconstriction is the number one, and then significant tachycardia follows closely behind, but limb ischemia is considered the most severe side effect that can happen. For contraindications, one important one is for any patient that has some sort of sulfite allergy. So we're not just talking anaphylaxis reactions to sulfa, but if they have any sort of sensitivity, you want to avoid use of dopamine. And there's another medication we'll talk about in a minute that has the same contraindication. So just keep in mind, if they have any sort of sensitivity or allergy to sulfa, don't use dopamine.
Hey, Sandra.
Yes.
So with dopamine being a precursor of norepinephrine, right?
Mm-hmm.
You don't see the variance, and if you give different dose sizes, you don't see the variance.
With Levophed?
In norepinephrine, yeah.
No.
Levophed? Okay.
Nope, that one is much more predictable, and dopamine is the only one that has that dose-dependent change with how it acts. So it'll, based on the different dosing ranges that you use, it'll either function at beta, alpha, or dopamine receptors. So the dopamine receptors are the ones in that middle ground where it gets a little hazy. So the other contraindication is pheochromocytoma, which is super rare, but very serious. So if the patient has that documented anywhere, do not use dopamine. The reason for that is that patients with pheochromocytoma, their tumor is secreting epi and norepi as well, and when it mixes with the dopamine that you're giving, it can cause some pretty toxic effects for that patient. Something else that's important is that the effects of dopamine are diminished if the patient has acidosis. So you might end up needing to increase your dosing of dopamine, which again gets a little weird because you're having to shoot at a different dosing range, so that could affect the way that your medication is going to work for the patient. The other important thing is that the dose reduction is needed for MAOIs, and that was something that we noticed in epinephrine and Levophed as well, that there is an MAOI interaction. So anybody know of any MAOIs off the top of their head? The most common one that we use here is Zyvox. We, for the most part, have avoided a lot of the antidepressants and psychotic medications that were MAOIs, and that's simply because they interact with so many medications that a lot of providers have fallen away from ever using them. So the main one that you'll see at our hospital that's on formulary is linezolid. All right, so the next one is dobutamine. It is also an adrenergic agonist, and it's a positive inotrope. It reduces your afterload, causes an increase in your rate and the cardiac contractility, which is what the action of a positive inotrope is. Causes increased cardiac output, mild dilation, and it essentially provides that extra squeeze that you need for cardiac decompression. So that's a good way to remember it. You can use it for cardiogenic shock, decreased cardiac output, as well as for heart failure. It shouldn't routinely be used in sepsis because it can cause significant hypotension. So it's why it's not one that we just immediately gravitate to. In terms of preparation, we carry premixes for dobutamine just like we do for dopamine, so it makes it really easy for you guys to be able to use it, have it available. You would start the drip at 1 to 2 mics per kg per minute, and you max out at 40. The onset of action, it's a little bit faster than dopamine. but again, not quite as quick as the epi or Levophen. The half-life is 2 minutes. And in terms of monitoring, it's important to monitor your BMP or potassium specifically, as well as to be having ECGs, blood pressure, all of the cardiac monitoring, and also be checking your pulmonary wedge pressure. For adverse effects, these play into the monitoring that you have to do. It can cause tachycardia, headache, hypertension, hypotension if the hypovolemia is not corrected, which can be incredibly severe for patients who are on dobutamine. So if you notice any patients that have hypovolemia, it's important to titrate the drip back down, correct that volume, and then restart at a lower rate. If the patient ends up experiencing hypovolemia again the second time after the dobutamine is restarted, it's very wise to consider switching agents. So again, you would titrate down and then switch to something else. It can also cause tachyarrhythmia and dysrhythmias. For contraindication, dobutamine is the other one that is contraindicated with sulfite allergy, and this is because both of them contain something called sodium bisulfate. The other interesting contraindication is that it is contraindicated for anyone who has any sort of hypersensitivity to corn, because the premixed formulations all contain corn products. So since that's the only formulation that we have here, it's an important one to notice. Every now and then Epic will kind of throw little tidbits your way when you're looking at a medication, and some of them are relevant and some of them don't always seem like they are. But if you have one that comes up saying this patient has a sensitivity to corn, pay attention and ask the provider to switch the medication. This is also a medication that has decreased effects in acidotic patients. There are a few of the drips that have that same reaction. The next one is phenylephrine. So phenylephrine and vasopressin, we talked about, have only the vasopressor action, and so these are not inotropes. They cause vasoconstriction, they decrease your heart rate, increase your blood pressure, and they stimulate the sympathetic nervous system. So phenylephrine is used for hypotension, hypotensive shock, and PSVTs. In terms of preparation, again, we'll make it for you. The bolus is a little more concentrated, by a little, I mean 5 times more concentrated. Stability is short, again, so it has that same 4-hour shorter stability at room temperature. If it's refrigerated, it's fine. So if you notice that phenylephrine gets ordered for someone and it's pretty quickly canceled, stick it in the fridge, or ask pharmacy to stick it in the fridge in case it gets reordered or reinitiated for that patient, then you haven't lost it. Onset of action, phenylephrine is like Levophen and Epi in that it has the rapid, immediate onset. It has a longer half-life, so if the phenylephrine does get stopped abruptly, it's still not recommended, but it might have a little bit less of an effect than if the Levophen or Epi are stopped abruptly. So in terms of dosing, it's separate for different types of indications, and I'll let you guys review that later. But in terms of hypotension shock, you would end up doing a smaller dosing. So just to get started, and then you transition to the continuous infusion, but they don't notice any sort of increase in efficacy when you increase above 6 mics per kg per minute. So then we're on to vasopressin, which is an antidiuretic hormone. It causes you to retain the water that's in the body. It'll constrict your blood vessels, increase blood pressure, increase the systemic vascular resistance, and decrease your heart rate. Again, this one's not an inotrope. For indications, it can be used for PEA, VFib, refractory shock, and can, unlabeled, be used for septic shock, but it's not one that you would just immediately reach for. In terms of preparation, again, just for your knowledge, you would start at 0.01 units per minute. Dosing range is pretty small, and this is a medication where the window for titration, it's pretty little. Like, you're not making huge dosing adjustments because you are using such small increments. The onset of action for vasopressin is also rapid. It has a half-life of 10 minutes, and it's important to be monitoring the blood pressure. For adverse effects, it can cause arrhythmias, cardiac arrest, angina, MI, and peripheral constriction. But all those side effects are more likely if the dose is greater than 0.04 units per minute. So for most patients, if you're using the lower doses, they won't experience any of the severe side effects. So it's relatively, or they consider it relatively safe, although it's not as readily reached for. So, dose adjustments, it's important to dose lower for the elderly patients, and again, you'll have a longer titration window for them. So a lot of the times you'll use a window of 20 minutes, just like the other medications we talked about earlier. Elderly, you may extend that to 30 or 45 minutes in between. The key point for vasopressin is that it is effective in acidosis. So as opposed to the others that we mentioned where their effect is reduced, vasopressin still maintains good efficacy if the patient is in an acidotic state. But it causes rapid rebound hypotension if it's stopped abruptly. So you want to titrate down by 0.01 units per minute when you're stopping. All right, this fun little chart you guys can refer to at a later time, but it'll point out for the vasoconstrictors and vasodilators which ones also have that same positive inotropic action. So the phenylephrine has the strongest vasoconstriction activity. Norepinephrine is just below that. Nitroprusside is, on the other hand, the strongest vasodilator. All right, so we're going to do a few questions. Which medications are contraindicated for patients who have a sulfite allergy? Beautiful. All right, if possible, what needs to be done prior to initiating vasopressors? You knew the answer before we started.
Hypovolemia.
Yep, correct the hypovolemia. All right, and which vasopressor is dose dependent and acts essentially as different medications at different dosing ranges? Good job. All right, now we get a fun one. And because in the ICU setting, you would check your math with another person. We're going to go through this math question, and you guys can check your answer with somebody else and see if you get the same one. All right, so patient's transferred to ICU. The physician orders an epi drip to start at 1 mic per minute. The patient is 75 kilograms, 5 feet 2 inches. His glucose is 96. He's lethargic and pale, now intubated on a ventilator. His oxygen saturation is 94%. He has adequate urine output. And the pharmacist, I bring you a bag of epi 1 milligram in 250 mLs of D5. What is your rate of infusion in mLs per hour? Okay, well, your calculator, it's okay.
Okay. 30.
Didn't even move my head. Okay. What?
Sorry.
Did you get your answer?
No, I was,
You're like, no, I'm
I was
watching.
waiting for,
Yes, good job. All right, 15, yeah. Okay, one more and then we'll resume. All right, so a 55-year-old male is in cardiac arrest. He's pulseless with waveform VFib on the monitor. He's receiving CPR and has had 1 AED, shock of 120 joules. VFib is still on the monitor. He didn't respond to the 1 milligram dose of epi. What would be the next drug of choice? Good job. What would be another alternate that's not up there?
Another dose.
Yeah? Or another low dose of epi if you wanted to see if he would respond the second time. All right, so moving on to vasodilators. We have nitroprusside, nitroglycerin, milrinone, and nicardipine. All right, so for nitroprusside, it is a potent vasodilator. It decreases your cardiac afterload. It can be used for hypertensive crisis, acute pulmonary edema, and CHF. For dosing, you stay typically within the 0.3 to 10 mic per kg per minute range. It's very important to start low and go slow. So you would typically do your titrations every 5 to 10 minutes until your mean arterial pressure decreases by 5 to 10 millimeters of mercury. So to prevent hypertensive crisis from occurring, it's important to not reduce the mean arterial pressure faster than 25% over the first hour. All right, so for some key points, it acts very quickly, it's reversed very quickly, it's essential to protect it from light. You do not want to use it in renal failure, or you increase your risk of causing cyanide toxicity. If a patient is on a nitroprusside drip for an extended period of time, you would want to be monitoring the thiocyanate levels just to make sure that they don't develop cyanide toxicity, or if you have any sort of concern that they might be. It's also important to not discontinue abruptly, or you can end up with rebound hypertension and seizures. For nitroglycerin, it's a nitrate, a strong vasodilator as well. It is a positive inotrope, dilates your coronary arteries, decreases preload, and is an anti-anginal and antihypertensive. For indications, it can be used for acute angina, hypertensive crisis, pulmonary edema, CHF, MI, and it is the drug of choice for cocaine-induced MIs. In terms of preparation, it's always in a glass bottle. It looks like this. Needs to stay light protected, so we're going to stick it back in. It needs to be used with vented tubing, which typically you guys would have immediately available, or we would send for you if you needed it. The concentration is 200 mics per ml. You start at 10 to 20 mic per minute, which is 3 to 6 mLs per hour. So for precautions, if the patient is on any other nitrate type medication, you would want to make sure that they're not at the same time that you start the nitroglycerin. So they would either need a nitrate window before starting the nitroglycerin, or you would have to pick something else. The reason for that is that it can cause life-threatening hypotension. For adverse effects, it can cause flushing, postural hypotension, reflex tachy, and dizziness. So it's important to monitor the blood pressure and the heart rate. Special considerations is that nitroglycerin does not have a max dose. So up until now, all of the other medications we've talked about do. Nitroglycerin is the one that does not. It's important to note that tolerance can develop after 12 to 24 hours, so you would want to have a nitrate-free period. At one point, they recommended a 4-hour window, and now they're noticing that's not sufficient. So instead, they're recommending if a patient is on a nitro drip for 12 to 24 hours, you would want to give them a 10 to 12-hour window after that before resuming. There is an antidote for nitroglycerin, and it's epinephrine, but you also need to decrease the rate, elevate the foot of the bed, administer IV fluids and oxygen. Now for nicardipine, it is much milder. It is still a vasodilator, and it's also a calcium channel blocker. It can be used for indications of hypertension, post-op hypertension, and chronic stable angina. All right, the most important part from this is to protect from light and do not refrigerate or freeze it. We supply it here as a premix. You would start at 5 mg per hour as an IV infusion. Typically the person's heart rate would end up decreasing by about 10% in that first hour. You would titrate 2.5 mg per hour every 5 minutes, or every 15 if you want to be a little more gradual. The max rate is 15 milligrams per hour, and once you reach the goal, you want to decrease to 3 milligrams per hour. Again, pretty standard monitoring parameters, except you also need to be monitoring their LFTs if they're on cardine. Adverse effects is that it can cause hypotension, peripheral edema, tachyarrhythmia, nausea, vomiting, MIs, and acute hepatitis, which is why it's important to be monitoring their LFTs. In terms of contraindications, it has a flat-out contraindication if they have aortic stenosis. So if that's listed, tell the doc, sorry, we can't use this. If you end up infusing cardine peripherally, it is necessary to change their IV site every 12 hours. So that's much more frequent than we typically would change their IV site. A lot of the times, we'll use a central line. But if something happens where you have to use cardine on a person with a peripheral line, make sure you're changing that line out every 12 hours. Now, milrinone is the one that fits in that really odd category of inodilators. So it is an inotrope, and it is a vasodilator, so they meshed those two together. In terms of indications, the only indication it's labeled for is acute CHF. So it has some other uses, but that's the only one that the FDA labels it. Again, this is available as a premix. The loading dose, you would start with 50 mics per kilogram IV over 10 minutes, and then you would work to a maintenance range of 0.375 to 0.75. It's important to note you would also use a much lower dose if the person has renal impairment. So the renal impairment adjustments aren't exactly standard. It's not a strict 50%. You would just want to be on the lower side of dosing. In terms of adverse effects, it can also cause hypokalemia. It increases your risk of arrhythmias if the patient is digitalized. So you either don't want to use this if this is a digoxin patient, or you want to just make sure that you're monitoring those EKGs really closely. It can also cause headache, hypertension, PDP, increased LFTs, bronchospasms, CVTs, SVTs, and thrombocytopenia. It has a lot of side effects, which is one of the reasons why we don't use it as often. Now, in terms of antiarrhythmics, we have diltiazem, amiodarone, digoxin, lidocaine, esmolol, labetalol, adenosine. There are many more, but these are just the ones that we're going to fly through real quick. So diltiazem is a calcium channel blocker. It is an antiarrhythmic as well. You use it for heart rate control during AFib, aflutter, AFib with RVR, and multifocal atrial tachycardia. The antidote, because it is a calcium channel blocker, is calcium. In terms of preparation, we have premixes available or add-ease options. You would initially give the 5 to 20 milligram IV push as a bolus, and that can cause some pretty acute rate control, but it won't last long. So infusion, you would start after that at 5 mg per hour, and then you would end up titrating by 2 to 5 milligrams every 15 to 30 minutes to a maximum of 15 milligrams per hour. Onset of action is 3 minutes. It does have a little bit longer half-life of 3.5 to 5 hours. That's only if it's IV. Monitoring the blood pressure, it's important to be monitoring your vitals again every 5 minutes because it can cause a rapid decrease in blood pressure. This is another one where you start low, go slow. Most of the patients will respond very well to a 5 milligram IV push. Some won't require being initiated on a drip after that. It is also contraindicated for use with wide complex QRS tachycardia. Amiodarone, another antiarrhythmic, used for life-threatening and recurrent VFib, hemodynamically unstable VTAC, cardiac arrest VFib that's pulseless, and VTAC unrespective to shock delivery and CPR. In terms of preparation, we have premixes available for you guys to get started with, and then we typically will send you a drip after that. You can give that 150 milligram bolus as a one-time bolus, or the physician may decide to repeat a bolus for that patient. Then you would typically start at 1 milligram per minute for 6 hours, and then you cut that rate in half for the next 18. The max infusion time that you can use for amiodarone is 24 hours. After that, you would transition to PO unless they have converted on their own, and then you just discontinue at that point. Onset of action is 1 to 30 minutes. It's pretty variable, so they don't have a correlation between younger patients having a quicker onset or older patients having slower. It's variable. Half-life is 9 to 36 days. Again, a very large range, so it is an extended half-life, and it's significantly longer for elderly patients. In terms of adverse effects, it can cause hypertension, bradycardia, proarrhythmic events, peripheral neuropathy, thyroid dysfunction, thyroid storm, nausea, vomiting, and pulmonary toxicity. So again, this is another one where it's essential to be monitoring a few other areas of that patient. So you'd want to be checking their T3, T4. You'd also want to be doing pulmonary function tests. It is crucial to remember that you cannot give amiodarone to someone if they are pregnant or breastfeeding, and it needs to be administered with an inline filter. The reason for that, it's associated with high incidence of extravasation, and extravasation of amiodarone typically results in phlebitis. So we like to avoid that if at all possible. It also is associated with high risk of photosensitivity, so if we have a patient where we get them started on amiodarone here and now we're sending them home, make sure they know to wear sunscreen if they go outside. Digoxin is used for chronic AFib, ventricular rate control, and heart failure, and it is never administered as a continuous infusion. You can give as IV loading doses, or you can skip the IV form altogether and go straight to PO. A lot of the times that's physician preference. Most of the physicians that we encounter here typically prefer the IV loading because it is a lot faster and it gets that patient to therapeutic goal at a much quicker rate. In terms of monitoring, when you order a digoxin level, depends on whether or not you did the fast IV loading or if you're doing a slow PO route. If you do the IV load, you can check the digoxin level about 12 hours after that third loading dose, as opposed to you'd have to wait 5 to 7 days to be able to check if they do the slower PO option. Therapeutic range is 0.8 to 2.1. It's important to monitor the electrolytes, specifically potassium and magnesium, as those will need to be replaced. Renal function, if the patient has renal impairment, they'll typically require a lower dose of digoxin or a longer dosing interval, so they can go either way. Onset of action is 5 to 30 minutes, has a half-life of 1.5 to 2 days, and that could be extended to 5 days for elderly. In terms of adverse effects, it can cause nausea, vomiting, dizziness, headache, cardiac dysrhythmias, sinus brady, vasoconstriction, and thrombocytopenia. It can also result in digoxin toxicity if the patient either doesn't know how to be taking their medication or hasn't been having their levels monitored and has been taking a much higher level or dosing of digoxin than their body needed. So this would present with arrhythmias, anorexia, nausea, vomiting, persistent diarrhea, confusion, weakness, blurred vision, green-yellow color disturbances, and halo effect. And it could be one of these, 2 of these, or all. The treatment for that I included here for you. Not something you need to necessarily commit to memory, just know that they would get Digifab. So if they don't know how much they ingested or their digoxin level comes back and it's greater than 10, you would give a standard 10 vials. And then they can re-administer another 10 vials again later after they see how the patient responds. Otherwise, they can calculate out the patient's specific dosing in vials based on whatever level they draw in the serum. So if it's within the range of, I guess, 3 to 10 vials, then you would be able to administer a smaller amount.
And that's given IV.
Mm-hmm. For lidocaine, it is used as a ventricular antiarrhythmic, and it suppresses the ventricular arrhythmias by decreasing automaticity. Who knows what automaticity is? Anybody?
The automatic electrical impulses sent out by the sinus nerve.
Good job. So proud. All right. Or impulse formation, I guess is the quick way to say that, but that was perfect. So it's used for ventricular arrhythmias. It's typically used as a premix. Again, ours is right here. The final concentration is 4 mg per ml. Your dosing would be 1 to 1.5 milligram per kilogram bolus initially. You can continue repeating those boluses for a total of 2 mg per kilogram. So if you started with a 1, then you can repeat an additional 1. If you gave 1.5, you can give an additional 0.5. Initiate the drip after that at 1 to 4 milligrams per minute. You never want to exceed the 4 milligram per minute, so that is a hard max. Onset of action is 30 to 90 seconds, and the half-life is 1.5 to 2 hours, slightly extended if you're elderly. In terms of adverse effects, it can cause confusion, hypotension, lightheadedness, double vision, seizures, tinnitus, or complete heart block, and that's really only seen in elderly patients who are on lidocaine drips. Contraindication, if the patient already has that complete or second-degree heart block, you don't want to initiate this. In terms of dose adjustments, you would want to decrease the dose by 50% for patients who have CHF, any sort of abnormal liver function tests, or a known hepatic disease, and an approximate 50% or about 45% decrease in dose for elderly patients. Then we have esmolol, which is a selective beta blocker, but it is also an antiarrhythmic. It decreases your heart rate, cardiac output, and SVR, and it decreases the cardiac oxygen demand. So it can be used for sinus tachy, to control your heart rate and ventricular response, for SVTs, and for hypertension. Again, this is another one that comes as a premix. Our premix actually is an NS, but the package insert recommends using D5, so it's compatible either way. If you have a patient who is diabetic, you might want to use the NS premix. If we had somebody with hypernatremia, you might ask that we prepare a drip instead that's in D5. In terms of dosing, you would give an undiluted IV push bolus over 1 minute and then start the drip at 50 mics per kg per minute, and you titrate up every 5 minutes. So the maximum is 300 mics per kid per minute for esmolol.
Do you wait between your bolus and your drip?
Yes, approximately 5 minutes. Onset of action is rapid, and the half-life is 9 minutes. So the goal between making those 5-minute titrations, it's about halfway from when, or your half-life is about halfway through. The monitoring, you want to closely monitor blood pressure as well as continuous tele and heart rate, and you do not ever want to stop this abruptly. Adverse effects, hypotension, nausea, seizures, bronchospasm, and MI. In terms of contraindications, it has several. So it is contraindicated if you have cardiogenic shock, decompensated heart failure, if you have other known calcium channel blockers that have just recently been administered. I listed IV administration because that's how the package insert explains it, but if there's any other calcium channel blocker that's been administered within 30 minutes of esmolol, you typically want to have a longer window than that. So you would look, see if there's any other calcium channel blocker that was administered recently, and then ask to wait or start something else and then add esmolol later if you needed to. Another contraindication is pulmonary hypertension, if they have the 2nd or 3rd degree heart block, severe sinus Brady, or 6th sinus syndrome. Then we have labetalol, which is an adrenergic receptor antagonist. It blocks non-selective competitive beta-adrenergic receptors and is a selective competitive alpha-adrenergic. It can be used for hypertension as well as hypertensive urgency. And one of the nice things about labetalol is that it's compatible with almost everything in terms of main IV fluids, not necessarily other medications, but in being able to mix it for you, we could use pretty close to whatever is available. It's just important to make sure your final concentration is 1 mg per ml. You would start with a 20 milligram IV push, then you can repeat at 10-minute intervals with 40 or 80 milligram doses to a max of 300 milligrams as IV boluses. After you're done with the loading doses, you would start the continuous drip, and you can start that closer to 5 to 10 minutes after that last loading dose. Get that continuous drip started at that point, and it would be at 2 milligrams per minute. You eventually end up transitioning labetalol to oral, similar to how you would for amiodarone or cardizem. Onset of action is 1 to 2 hours. It has a longer half-life of 5 to 8 hours. Monitoring is your BMP, LFTs, blood pressure, and orthostatics. Main reasons for that are for the adverse effects. So labetalol can cause bronchospasm. Orthostatic hypotension is one that over 60% of patients who receive labetalol experience, so very important to be monitoring that. Hyperkalemia is very likely, and it also causes hepatotoxicity. So it's important if we can get a baseline LFT for that patient, LFT panel, to be able to compare and see how the patient is tolerating it. If their LFTs start rising, you typically want to transition them to something else. In terms of contraindications, if the patient has any sort of obstructive airway disease or asthma, that would be a contraindication for the patient if they have severe bradycardia or 2nd or 3rd degree heart block. And then in terms of dose adjustments, because of the risk of hepatotoxicity, you would want to use 50% of the dose for liver impairment. And geriatric, they don't give IV dosing adjustments, but when it comes to maintenance PO regimens, you give a much lower maintenance dosing for geriatric patients. Then for adenosine, it is a very strong vasodilator that is also an antiarrhythmic. It modulates the sympathetic neurotransmission and decreases your vascular tone. It blocks faulty circuitry in the heart, slows conduction time, and causes transient asystole. So we use it for PSVT as well as for Wolff-Parkinson syndrome, which you won't see all that often, but in terms of dosing, for PSVTs you give a 6 milligram rapid bolus very quickly, and it's also important to make sure that you follow that with a saline flush. If it's not effective, then you can give twice that bolus. So you would start with the 6, see if it works for the patient. If not, repeat with 12 milligrams. You can then give an additional 12 milligram bolus if the SVT is still persistent. The max to give in any single time is 12 milligrams. And the important thing to know is adenosine is never given as a continuous infusion. For onset of action, it is immediate. The half-life is less than 10 seconds, so it's very short. And monitoring, it's just important to be monitoring your ECGs. For adverse effects, it could cause chest pain, shortness of breath, flushing, and headache. And it's contraindicated if there's any suspected bronchoconstriction or bronchospastic lung disease, second or third degree AV block, or sinus node disease. If the patient doesn't have a pacemaker. If they do, you can go ahead and use the adenosine. All right, more questions for you. So, which antiarrhythmic requires an inline filter? And do you remember why?
That's the possible infiltration.
Yeah, which causes phlebitis. All right, which strips require light protection? Mhm. Mhm.
All the nitrogen.
Yeah, levofed too.
Yeah,
And nicardipine. But nicardipine's a little different because you only have to protect it until you start using it. A lot of the times we still will, just so it maintains the ability for us to keep that same drip going for 24 hours, but it's only essential to keep it light protected until it's used. All right, and what's the antidote for diltiazem? All right, so the most important points to take away from today, because all of the dosing can be looked up and the dosing parameters and all of that, is to choose the initial agent based on what the suspected underlying etiology is, to titrate the dose to achieve the effective blood pressure or heart rate, or end organ perfusion. If the max dose of that agent that you selected is not adequate, then you would add the second agent, but you always want to max out the first agent first before you just start adding additional ones. Responsiveness might decline over time, such as with which medication that needs a nitrate-free period? And nitroglycerin, yep. And you can end up with higher side effects that experience as the patient stays on a drip for longer. It might be harder and harder to get them off. Central line is always preferable, and which medication has a labeled antidote for extravasation? Yeah. Does anybody remember what it's called? Phentolamine, yeah. All right, bioavailability, this is one that we didn't touch on yet, but the bioavailability of subcutaneous medications is reduced while you're administering vasopressors. So patients who are in the unit who are receiving vasopressors or in the OR, if they are also receiving sub-Q heparin or sub-Q insulin, they might need higher doses. So if someone is a diabetic who's on insulin at home on a regular